Good morning everyone. I am Dr. Divyakant Parmar, working as Associate Professor in Cardiac Anesthesia at UNMICRC. Continuous cardiac education program is running since last 1.5 years. So as a part of it, I am going to talk on peripheral arterial disease and anesthesia management. The outline of my talk includes the what is peripheral arterial disease, and risk factors of peripheral arterial disease, pathophysiology, signs and symptoms, medical and surgical management, then other entity, that is acute arterial occlusion, signs, symptoms and treatment, and lastly important part, that is anesthesia management for revascularization procedure. Starting from introduction, peripheral arterial disease is defined as the narrowing or blockage of peripheral arteries, that is outside of the heart, aortic arch and the brain, resulting in reduced blood flow to the extremities by atherosclerotic or inflammatory processes. It is most commonly involved the arteries of the lower limb. It is very important because despite its high prevalence, it is commonly underdiagnosed and leads to an increased risk of cardiovascular death, major tissue loss, poor quality of life and increased rate of depression. Coming to the causes of peripheral arterial disease, atherosclerosis is the most common cause of PAD, that is that results from the accumulation of lipid and atheromatous material in the walls of the arteries, causing the narrowing of the lumen. Other rare causes are the Purger's disease, vasculitis and cystic adventitial disease. Coming to the risk factors for developing peripheral arterial disease, these are the same as those for the ischemic heart disease. First one is the age. As the age increases, the chances of progression of PAD will be increased. It increases greater than 70% if the age is greater than 75 years. Male dominance, then increased chances of PAD. In case of diabetes and hypertension, it also accelerates the progression of atherosclerosis. Smoking, then obesity, dyslipidemia, hyperhomocystinemia, and lastly family history of peripheral arterial disease or stroke or MI. Out of all these risk factors, smoking is the most significant risk factor, as it increases the progression of the peripheral arterial disease more and also doubles the risk of other cardiovascular events compared to non-smokers. Now, why it is more common in smokers? So, in this patient's blood, carbon monoxide combines with the hemoglobin, forming the carboxyhemoglobin, and this will lead to increased affinity of carbon monoxide for hemoglobin is greater than the oxygen. It also shifts the oxyhemoglobin curve to the left side, leading to chronic tissue hypoxia that will stimulate the increased production of hemoglobin, red blood cell, platelets and fibrinogen that eventually increase the hematocrit and blood viscosity, leading to increased thrombotic tendency of blood. Therefore, the incidence of arterial thromboembolic disease is more seen in smokers, that is around 4 to 5 times compared to non-smokers. Coming to the pathophysiology of peripheral arterial disease, one of the most common mechanism is atherosclerosis, as I have told previously, that will cause the narrowing of vascular lumen. Second one is the vascular remodeling, that will cause thickening of vascular wall. Third is the endothelial dysfunction leading to decrease in nitric oxide production. Lastly, the thrombosis, that is that may be acute due to emboli leading to vascular blockage. All these factors cause the reduction in vascular blood flow, leading to development of skeletal muscle ischemia during exertion, leading to mismatch between the oxygen delivery and supply, and this will lead to peripheral arterial disease development. Peripheral arterial disease involves the atherosclerotic disease in the abdominal aorta, iliac and the femoral arteries. It can be asymptomatic because it takes more time to develop and gradually it occurs. And second thing is it due to the presence of the compensatory mechanisms like vasodilatation and the collateral circulations. In the early stages of peripheral arterial disease, the arteries compensate for the plaque buildup by dilating to preserve flow through vessels. Later on, the artery cannot dilate any further and this plaque starts to narrow the arterial flow lumen. As the narrowing progress and completely obstructs the artery, the blood flow shifts to smaller arteries that is parallel to the main artery called collateral circulation that will preserve the distal perfusion. Now, why intermittent claudication and rest pain occur in these patients? So, intermittent claudication occur when the metabolic requirements of exercising skeletal muscles exceeds the O2 delivery. So, that will not compensate by the stenotic blood vessels. So, this will lead to intermittent claudications. And rest pain occurs when the minimal nutritional requirements of the skin of the affected extremities is not fulfilled by the stenosed blood vessels, that will cause the rest pain. So, rest pain occurs due to the cry of the dying nerves. The symptoms and signs of peripheral arterial disease, it is most commonly asymptomatic in 60% of patients, as I have told previously. Then intermittent claudication is the most common presenting symptom, that is the patient complains of cramping, muscle pain, most commonly in the calf, that is aggravated by the walking and relieved by taking rest. While rest pain burning in nature and ischemic and occurs at the foot, commonly at the night, and it is aggravated by elevating the foot and relieved by putting the leg at the bedside. On examination, these patients have decreased or the absent arterial pulses or roots over the abdominal aorta or the affected vessels. Non-healing skin lesions like ulcer or gangrenous changes may be found at the distal part of the foot. Some patients have signs of chronic leg ischemia, that will include the subcutaneous atrophy, hair loss, coolness or pallor, cyanosis and the dependent redness. Patients may present with acute limb ischemia, that is defined as chronic ischemic rest pain, ulcers or gangrene in a patients having peripheral arterial disease. So, peripheral arterial disease is a spectrum ranging from asymptomatic to acute limb ischemia. Various patterns seen in peripheral arterial disease, these are the aortoiliac, femoropopliteal or the infrapopliteal disease, and multivessel disease is also common. Diabetic patients often have infrapopliteal disease. Symptoms during walking occur in the muscle group one level distal to the artery stenos. If it is a aortoiliac disease, then pain occurs at the buttock and the thigh. In case of femoropopliteal disease, the pain occurs in the calf. Coming to the diagnosis, the ankle brachial index, that is the quick screening method used for the diagnosis. It is also used to estimate the severity of peripheral arterial diseases. And how it is measured, as you see in this figure, it is the systolic pressure of the ankle and the brachial artery is measured with the handheld Doppler probe. So, ankle brachial index is the systolic pressure of the ankle divided by the brachial systolic pressures. Normally it is 1 to 1.1, that means the ankle pressure and the brachial pressures are almost same. If it is less than 0.9, then it indicates the peripheral arterial disease. If it is between 0.3 to 0.9, then claudication may occur. If it is less than 0.5, then more severe, that is rest pain occur. In case of less than 0.2, then gangrenous changes may be present. If it is 1.3 or more than 1.3, then the vessels are usually calcified and non-compressible. So, this may be found in diabetic patient or the renal failure patients. Doppler USG and the resulting pulse volume waveform is also used to identify arterial vessels with stenotic lesions. This figure shows the Doppler waveforms. Normally the Doppler blood flow signal is triphasic. As you can see in this figure, the first phase is due to the systolic forward flow, followed by the early diastolic flow reversal, and lastly the late diastolic forward flow occurs. In case of biphasic flow, there is absence of either of the diastolic phases. So, it may be normal or may indicate the mild to moderate peripheral arterial disease, or patient may have calcification. In case of monophasic, only one phase present, and that is always abnormal, indicates the peripheral arterial disease. CT angiography or MRI can be done when the diagnosis is in doubt, or when a decision for endovascular intervention or surgical reconstruction is planned. It will define the sites of arterial stenosis and the extent of disease. Moving to the management of peripheral arterial disease, that will aim towards the decrease incidence of the cardiovascular and the limb related event, decrease the limb related symptoms, and improve the quality of life. This includes the risk factor modification and the medical therapy. Risk factor modification includes the cessation of smoking, that is more important, then supervised exercise program and the lifestyle changes. In medical therapy, antihypertensive treatment should be continued to control the pressure and decrease the cardiovascular related events. In diabetic control, and statins should be indicated in all patients of peripheral arterial disease, as in case of as patients of ischemic heart disease. So, it has advantage like it stabilize the plaque formation and decrease the progression of peripheral arterial disease. Antiplatelet like ecosprin and clopidogrel should be continued for decrease the progression of the peripheral arterial disease. And cilostazol, that is phosphodiesterase inhibitor, is used to decrease the claudication, and it causes the dilatation of the arteries, and it is contraindicated in patients with congestive heart failure. And lastly, the pentoxifylline may be used to decrease the claudication, and it increase the O2 delivery to the peripheral tissues. Now, when the medical therapy fails, revascularization, that is endovascular or the surgical therapy indicated in these patients. The indications are disabling claudications, ischemic rest pain, non-healing wound, that is ulcer or the gangrene, and impending limb loss, especially in acute arterial occlusion. So, this revascularization selection between endovascular versus open surgery should be decided based on the site of arterial stenosis, extent of disease, and the comorbidities which is associated with PAD, and the anesthesia risks, prior any intervention done or not, and durability of the intervention. Endovascular, that is angioplasty with or without stenting, is preferred when the lesions are focal in the vessels and stenosis present, the stenosis involve the larger vessels. Like if it is present in the iliac artery, then angioplasty with or without stenting is good compared to femoral artery, but only problem is restenosis after the stent. Open surgery with bypass graft is preferred when the lesions are long or diffuse, and when there is a complete occlusion of vessel is present and the vessels involved are very small or diffuse, like in diabetic patients. The advantage is that this bypass graft lasts longer compared to stenting, but cost is more and risk is more. Coming to the surgical management, the procedure for surgery will depend on the location and severity of the arterial stenosis of peripheral arterial disease. Endarterectomy can be done to remove the segment of the atherosclerotic plaque. Bypass grafting can be done with use of saphenous vein or the prosthetic grafts. Saphenous vein is better graft for the intrainguinal procedures, and prosthetic grafts can be used which has high failure rates and also costly. In case of aortoiliac disease, aortobifemoral bypass or the axillobifemoral bypass can be done. In case of unilateral iliac artery disease, femoral bypass is done, and femoropopliteal bypass is done in case of intrainguinal procedures. In severe cases where there is gangrene occur, then amputation may be required. Revascularization in these patients is associated with significant cardiac related morbidity and the mortality because of the associated coronary artery disease, diabetes, renal problem, respiratory and the cerebrovascular diseases. Mortality in these patients is usually secondary to MI in patients who have ischemic heart disease, congestive heart failure or post CABG patients. In patients who have advanced ischemic heart disease as well as claudication, treatment of ischemic heart disease like angioplasty or CABG may be considered before performing revascularization surgery. Coming to the acute arterial occlusion, it is a emergency condition and it will reflect the systemic emboli that originate from the heart or outside heart. The sources of emboli originating from the heart includes the mural thrombosis in the left ventricle secondary to MI or dilated cardiomyopathy due to the decreased conductivity of the heart, valvular heart disease, especially the mitral stenosis, then prosthetic heart valve, infective endocarditis or left atrial myxoma. Atrial fibrillation is the most important factor in systemic embolism associated with valvular heart disease. Non-cardiac causes include the atheroemboli originating from atheromatous lesions in the abdominal aorta, iliac or the femoral artery. Aortic dissection or the trauma may also acutely occlude arteries by disrupting the integrity of vessel lumen. Symptoms and signs of acute arterial occlusion include, in early cases, patient have absent pulse and severe pain in the affected extremities, then cold peripheries, then and pallor. While in late stages there is sensory and motor involvement, there is paresthesia and the paralysis of the affected extremity occurs. Diagnosis required Doppler USG or the arteriography to define the site of acute arterial occlusion and appropriateness of revascularization surgery. Coming to the management part, this acute ischemia should be rapidly addressed and evaluated because irreversible tissue injury occur within 4 to 6 hours. So, surgical embolectomy is done to treat the acute systemic embolism to a large peripheral artery. Anticoagulation with heparin is started to prevent propagation of the thrombus. Intra-arterial thrombolysis with urokinase or recombinant human tissue plasminogen activator may restore vascular patency in acutely occluded arteries, and synthetic bypass graft. Amputation can be done in some cases where the patient presents late with already discoloration and the gangrenous foot. Coming to the anesthetic management of peripheral arterial disease, first part is the preoperative assessment. So, this peripheral arterial disease is the systemic disease. So, full blood investigations are required, and out of this HB, hemoglobin, platelet count, prothrombin time and the APTT get done, because these patients are taking antiplatelet, blood thinners and the anticoagulants. So, these may be affected. Then lipid profile should be done as just to know the cholesterol level and cause of this peripheral arterial disease. In respiratory system, patient may have history of smoking and COPD. So, preoperative evaluation of respiratory function helps to determine whether regional or the general anesthesia is appropriate. It also provides the baseline values for post-operative comparison. So, chest X-ray get done, and also consider pulmonary function test and the ABG. In CVS, peripheral vascular surgery is associated with morbidity and mortality secondary to incidence of coronary artery disease and hypertension in these patients. So, ECG and 2D echo get done. Now, from this history and examination, some clinical predictors of preoperative risk should be identified, and based on this predictors, it is divided into the major, intermediate and the minor categories. In major category, patient has history of unstable angina or MI within 13 days, congestive heart failure, then significant arrhythmia and the severe valvular heart disease. In intermediate category, patient has history of mild angina pectoris, previous MI that is greater than 30 days earlier, diabetes and the renal insufficiency. In case of minor category, patient's age is greater than 70 years, abnormal ECG, non-sinus rhythm, history of stroke and uncontrolled hypertension. So, based on this risk factors, if patient has intermediate clinical risk factors with unable to meet a format, then patient should undergo non-invasive testing, which includes the exercise stress testing, dobutamine stress ecography or the myocardial perfusion scanning. And if any of these tests positive, then coronary angiography should be advised, and if required, myocardial revascularization with stenting or the bypass grafting should be done first. After that, if peripheral vascular surgery required, then it should be delayed for at least 4 to 6 weeks after balloon angioplasty, coronary stenting or the bypass surgery. Neurological assessment should be done to document existing deficit, as these patients have higher incidence of the cerebrovascular disease. There is also increased incidence of renal disease and the renal insufficiency. So, blood urea, creatinine and serum electrolyte should be done. Due to associated diabetes mellitus, these patients have peripheral and autonomic neuropathies. So, preoperative blood sugar and HbA1c should be done. Coming to the preoperative preparation and monitoring. So, all the drugs, mainly the beta blockers, antihypertensive and antiplatelet agents should be continued till the day of surgery. Out of these, the beta blockers are most important because it will reduce the incidence of perioperative myocardial ischemia, it will decrease the cardiac morbidity and decrease the perioperative arrhythmia, but it should be started minimum 7 to 10 days before the surgery, and the optimum heart rate should be at 50 to 60 per minute. Monitoring includes the electrocardiogram for signs of myocardial ischemia. Arterial lines should be placed for continuous blood pressure monitoring and the blood sampling like ACT, activated clotting time, for the intra-op and the post-op management. Unique catheter should be done for assessment of intravascular volume and the cardiac output. Central venous catheters should be considered only in severe cases where the ventricular dysfunction present or the congestive heart failure or the renal dysfunction occurs, in whom intravascular volume should be carefully monitored. Coming to the anesthetic management. Now, the question of whether regional or the general anesthesia is preferable for vascular surgery has been debated for many years. Many clinicians believe that regional anesthesia was safer for patients with advanced cardiac or the pulmonary disease, but overall optimization of perioperative care rather than anesthetic selection is most important factor in improving patient's outcome. Anesthesiologists must consider the anticoagulation agent use and duration of discontinuations and the current coagulation profile before considering the regional anesthesia or the general anesthesia. The goal during anesthetic management is to maintain the hemodynamic stability and prevent the myocardial ischemia during perioperative periods. So, avoid tachycardia and the hypotension that will precipitate the myocardial ischemia. Avoid hypovolemia as well as hypervolemia. Avoid anemia, keep the HB at least greater than 9. Maintain normothermia, as hypothermia will increase the SVR and the increase O2 demand, further precipitating the myocardial ischemia. Regional techniques should be performed 12 to 24 hours after last dose of low molecular weight heparin. Hypotension can occur with epidural or spinal anesthesia and should be treated with judicious use of fluids and vasopressors. When hypotension results from sympathectomy, low dose phenylephrine bolus is also helpful in reducing the IV fluid requirements. During epidural anesthesia, when a test dose is given, then watch for heart rate and blood pressure. Out of these, blood pressure is more reliable indicator of intravascular injection, as these patients may have little or no increase in heart rate due to beta blocker therapy which is ongoing and age related decreased alpha responsiveness. Advantage of regional anesthesia includes it will lead to increased graft blood flow post-operatively. It causes less increase in SVR with aortic cross clamping due to vasodilatation, and it is also useful for the post-operative analgesia. It improves the post-operative respiratory function. It causes less activation of coagulation system by attenuating the post-operative as well as intraoperative stress induced hypercoagulability. But caution should be required, as spinal or epidural hematoma may occur, and it is a potentially devastating complications leading to permanent neurological injury. So, it is recommended that surgery can be cancelled when blood is obtained through the needle on placement of regional block. It is not preferred in presence of drug induced anticoagulation. Congestive heart failure may result in post-operative period when sympathectomy resolves and the intravascular volume contracts, leading to hypervolemia. General anesthesia. Surgical procedures like embolectomy and femoral pseudoaneurysm repair should be completed with patient under local anesthesia with mild IV sedation. As these patients are taken in the emergency procedure, and these patients are not also kneel by mouth, so chances of aspiration will be also more. General anesthesia is delivered by balanced technique with opioids, inhalation anesthetics, nitrous oxide and neuromuscular blockage. In the induction, avoid the high dose of opioids as these patients are extubated in the operating room. Maintain with low dose inhaled anesthetics, sevoflurane or isoflurane in 50% nitrous oxide with 3 mics per kg of fentanyl. Infrarenal aortic cross clamp in presence of peripheral vascular disease with adequate collateral circulation is associated with fewer hemodynamic derangements because of the collateral circulation that will prevent the marked increase in lactate during the cross clamp period. Heparin is usually administered in 100 to 150 unit per kg before application of aortic cross clamp to decrease the risk of thromboembolic complications. Distal emboli, especially to the kidneys, reflect dislodgement of atheroembolic debris from the diseased aorta. So, careful manipulation and clamping of the aorta should be done to minimize dislodgement of potentially embolic debris. That is more important than heparin administration. Peripheral nerve block due to relative risk associated with neuraxial anesthesia in patients with anticoagulant or antithrombotic therapy. Some clinicians advocate the use of peripheral nerve blocks like sciatic, femoral, popliteal or ankle block. It is better to use with USG guided or with use of peripheral nerve stimulator. Caution should be required in anticoagulated patient due to nearby location of vascular structures to neural structures. Systemic toxicity may occur in this patient due to a high volume of local anesthetics. Recent studies shows no difference in graft function, cardiac morbidity or mortality between regional anesthesia or the general anesthesia. Graft flow depends principally on surgically expertise and majority of post-operative graft occlusion caused by technical surgical factors. But graft flow is also determined by cardiac output, vascular resistance and circulating blood volume. So, avoidance of hypothermia, hypovolemia and pain by meticulous anesthetic management are also more important factors in graft patency than the use of either general anesthesia or regional anesthesia. Coming to the post-operative management. In the post-operative period, pain and anxiety should be controlled very well because stress response and myocardial ischemia are greatest concern at this time. Provide analgesia with neuraxial opioids. Monitor ECG for signs of myocardial ischemia as silent MI may occur in patients with CAD during this period. Optimize the intravascular volume. Avoid anemia by keeping the hemoglobin greater than 9. Peripheral pulses at the dorsalis pedis or the posterior tibial should be checked frequently to verify lower extremity graft patency. Blood pressure should be kept at higher side 120 to 130 systolic, and anticoagulation should be started with heparin whenever required, especially when peripheral perfusion is limited. Urgent surgery may be required in case of clotted or the stenotic grafts to reopen this blocked graft. So, to summarize this talk, peripheral arterial disease is a manifestation of atherosclerosis. It is associated with a high risk cardiac morbidity and the mortality. Preoperative cardiac risk assessment is important and risk reducing measures should be started. Quality of anesthetic practice rather than specific technique per se is more important. These are the references from which I have collected this information. Thank you.